than a normal heart rate for the child age level of activity. So if the child age is newborn, the heart rate is almost 140 to 180. But if it's 10 years, the heart rate possibly maximum should be 100. So if you have a child with bradycardia, like heart rate below 60, but in neonatal age below 90, it can be sinus bradycardia or nodal rhythm or heart block, 3 grades. And in this approach, usually we look for the following points: absent P wave, single P wave, or multiple P waves, or there is no relation between the P wave and the QRS complex, and this is really very dangerous. This patient has a sinus bradycardia. Sinus bradycardia is slow heart rate than normal, usually benign during sleep, athletes, and in hypothyroidism. So is all sinus bradycardia is benign? No. Sinus bradycardia may be a sign or a flag of very serious condition like hypoxia, hypotension, and severe acidosis. And in sinus node dysfunction, we will touch this later on. In sinus bradycardia, there is 2 phenomena we call sinoatrial block if complete cycle only, 1 cycle only is dropped. But if more than 1 cycle is dropped, we call it sinus arrest. If this block more than 3 seconds, we call it serious sinus arrest, and this will need pacemaker. This 1 cycle, which is dropped, we can call it sinoatrial block, and this is a picture of sick sinus syndrome with sinus arrest. When we do Holter for any patient, if he has sinus arrest, we should stress on the time, the period of sinus arrest, whether it is less than 3 seconds or more than 3 seconds. Sometimes you have bradycardia because the sinus node is not functioning. Well known that the physiology of the AV node is to fire on a rate less than sinus rhythm. The definition of junctional rhythm is narrow QRS complex with absent P wave before. Sometimes P wave will come after because the direction of the impulse is coming from down up. The heart rate usually is low, except after some surgery when you have accelerated junctional rhythm, especially with hypomagnesemia. So if you have accelerated junctional rhythm, that means sinus node is not functioning because of the complication of surgery, and the magnesium of the patient is very low. Sometimes with correction of magnesium, he will improve. If not corrected, you need external pacemaker. If continued more than 2 weeks, we may implant permanent pacemaker. Sometimes there is a delay in the sinoatrial node. That if the delay is fixed, we call it first-degree heart block. There is many causes for first-degree heart block. Sometimes even you see it in normal patients, and the PR is fixed, as I told you. And sometimes the wave takes long time to pass through the AV node. So the PR interval will be prolonged more. Then 1 wave or 1 cycle will be dropped. We call this Mobitz type 1 AV block. If there is fixed rate between the atria and the ventricle, there is 2 P waves and 1 QRS complex, we call it Mobitz type 2. This one a little bit more dangerous than Mobitz type 1, and sometimes it needs pacemaker. Let me discuss with you this case. You called to see this neonate, not because of the skin rash, but because the heart rate of this neonate is 60 per minute, sometimes during sleep goes down to 40 per minute. With this rash, we can diagnose congenital lupus. And in congenital lupus, there is antibodies that attack the mom, the cells, the conductive cells of the baby. This antibodies coming from the mom circulation. And if it causes minimal inflammatory changes, this will be first or second degree heart block. But if engulfs all the conduction system by the macrophages and apoptosis will happen at this of the cells of the conductive system, this will give us complete heart block. Incomplete heart block, as you see, there is no relationship between the P wave and the QRS complex, but the relationship between the P wave itself is regular. And the P wave, if you count them, is more than the QRS complex. And this is really important in diagnosis complete heart block. So if you have neonate, usually it can happen in infant of SLE mom, sometimes incorrect transposition of the great arteries. And we have risks of congenital heart block if symptomatic, and with time will lead to LV dilatation. If the QRS complex are wide, the escape rhythm here is not from the AV node, it's from the ventricle. So you have dilemma and problems in the AA node, in the SA node and the AV node. And if the heart rate is less than 50 in infant, or less than 55 in infant and 50 in child. And if you have significant or severe complex congenital heart disease, even in such age group like 8 weeks or more, a little bit advanced age, we can have pacemaker insertion to the child to save his life. In what we call the AV dissociation, which is common in adults more than pediatrics, you will find escape rhythm from either the AV junction or the ventricle during sinus bradycardia, but the ventricular QRS rate is higher than the atrial P wave rate. And this is the opposite in third-degree heart block, where the QRS is less than the P wave. We have types of pacemaker, either single chamber pacemaker or dual chamber pacemaker. Single like atrial pacemaker, dual chamber like atria and ventricle. Sometimes we have CRT, which is biventricular pacemaker, so it will include right atrium, right ventricle, left ventricle. In single chamber pacemaker ECG, if you look at the ECG, you will find the inverted M, which is the left bundle branch morphology. Pacing spikes is before the QRS, not before the P wave, and you will find AV dissociation. In dual chamber, you will find again left bundle branch block morphology, pacing spike before the P wave, and also before the QRS complex, one or both. And you will find sequential AV pacing, no dissociation. Sometimes you will see abnormal pacemaker ECG, like failure to capture. Here, the pacemaker spike is present, but there is no capture from the ventricle or the atria. It was before the ventricle in the previous cycle, so this is a single pacemaker. Sometimes you will find failure to sense. The spike is here, but no sense from the ventricle. Or you can find pacemaker-mediated tachycardia. The pacemaker is generating in a higher rate. In pediatric bradycardia, if you want to do CPR, usually we differentiate them, as you know, between stable patient and non-stable patient. If the patient have hypotension and acutely altered mental status or signs of shock and heart rate is below 60, you start CPR. If there is persistent bradycardia, there is two medicine. We like to use them in this bradycardia, epinephrine and atropine. So if you face one patient with persistent bradycardia and he is asymptomatic at the time being, you can be ready with the epinephrine and a syringe and the atropine in a syringe beside the patient, plus the CPR crash cart. You should know the normal ECG before you diagnose abnormal ECG, because the eyes do not see what the mind does not know. Take home message to me and you. we should always treat the patient, not the monitor or the ECG. Thank you so much.
Thank you, Dr. Magdi. Very nice presentation. I'm opening the floor for questions. We have a few minutes for questions and answers. Seems that your presentation was very clear. Thank you, Dr. Majdi. Are you there with us? Okay, thank you very much.
Thank you. We always say ختامها مسك, and I do believe that today also ختامها مسك. We have today Dr. Abdurrahman Al-Gharib. I think I don't need to introduce him. He's a flag in Bahrain, and he's one of the eminent consultant ENT doctor in Bahrain. And according to what is mentioned in the paper, he's taking a certificate every 3 years, and he's continuously taking and taking and taking. So from Germany, a lot of certificate, and from America also a lot of certificate. So I think it will take a long time to mention all what he achieved, but I think what he achieved is well known for all of us. The floor of you for Dr. Abdurrahman today will give us about a very important topic, which is about obstructive sleep apnea in the children.
Thank
The
you
floor
very
is
much
yours.
for the
Thank you.
introduction. Thank you. Pitaji, it is my honor to be with you today here and speak in front of this hybrid and virtual meeting. Thank you very much. Just a few days back, we just finished quite relatively 4 days conference gathers ENT community and bariatric surgeon and oral maxillofacial surgeon all talk about the sleep and sleep problem and how we can improve. It was very interesting. But today, to be with you in a pediatric meeting, it's prove only one fact, which we always try to emphasize that this is a multidisciplinary platform for everyone. There is a place for sleep. It became, by the way, the biggest subspecialty. It covers ENT, respiratory, neuro, psycho, pediatric, geriatric, economy, aviation, just name it. So all those subspecialty has a big chop in the sleep medicine. So how can I get out of this? I don't know, something going wrong? Okay.
تليفون هو
Just click that one. Okay, just go forward, right?
Just 1 second until I make it full.
Okay, so we'll speak about sleep. It's a magic. Basically, it is the pillar of life. When we speak,
No, from your side.
when we speak about the pillar of life, people speak about lifestyle, about exercise, and about diet. And most of, nutrient believe that the sleep is the main pillar of life for healthy life. Without a good night's sleep and shut eye, you will never have a good, stable mental and health and body. So I can proceed even without that. So let us see how it works. So basically, when we speak about sleep, we have to know something called sleep cycle. Sleep cycle is the alternate stages of sleep started by stage 1, stage 2, stage 3, that we reach the deep sleep stage. And then After that, we shift to the REM stage, rapid eye movement stage, which is the dreaming sleep. So in these two stages, basically, it goes alternate until we are waking up in the morning. We just remember the latest dream we've been there. So no surprise. It works like every day we are doing a lot of work. And all this work goes exactly the same as the laptop now with jump and change. So all the all the information is on the we gather it on the day. It needs time to process, like information in the desktop now going on. It takes some time to go on the hard disk. And that is exactly the function of sleep. It's the hard disk of everything. So you can store everything. So during that stages of sleep, so I think it is settled down right now. Okay, so that was a little bit introduction, rapid eye movement, sleep stages, cycles, and we know now we need that portion of sleep, a full sleep cycle. If you don't take that sleep cycle from A to Z, minus 10, 15 minutes for that full sleep cycle, it considers zero. So you are on debt because of losing of that amount of sleep. So back to the speak about children. They have their own. It is different than adult. Same as old people, they are different than normal sleep. Same as female, they have also different pattern than normal sleep. So we have to know the specific type of sleep for each category of people. Then we can understand things. When I speak with the shift worker, they have also their own pattern of the sleep. So we have to understand these details. Only then we can help people with a sleep deprivation, sleep problem. When we talk about children, they spend, so many hours in bed. When they are between 4 and 12 months, they spend up to 16 hours sleeping. They spend up to 14 if they are come to be 2 years old, and then 13 hours when they are 3 to 5 years. When they at school age, they spend up to 12, and then at teenager, they spend up to 10. But you can see the nap is restricted afterward. There is no nap. They take nap at the beginning. Why? Here is the trick. They need something to regenerate and process making in the brain. That's why they need that naps. And also, when you look at how it is increased the time and duration of sleep needed by different category of children at the different. It tells us that this is very important to consolidate all the information. If you don't have that time, include the naps, that's why children, they need every single relax and sleeping and napping to consolidate and process all information they are gathering during their life. So that is covered here. So we find some problem. Prof. Bataji mentioned about the circadian sleep stages in the children and the teenagers. Exactly, they have different style of sleeping. They are not night owl. They are stay longer, but their hormone works to shift their sleep pattern. They tend to sleep late and wake up late, and this is a very, very important message for the community. Our kids are sleeping, they are sleepless, they don't sleep at night. Yet they have to wake up very early morning and go to the school. And that raises a very important message internationally, like alarm. Our teenager in the school, they shows low educational performance because they have lack of sleep. You cannot force them to sleep. That is their nature. They have to stay awake. They have to play with the gadget. But if you give them 1 hour late, school start time 1 hour late, only 1 hour, that changed dramatically all their academic performance. Okay, so how it works down here, I don't know. Yeah, important sleep. Sleep is the primary, I don't know what I'm doing here. It's rushing. Our kids, children, especially, they need the sleep to include for the growth and for lack of sleep that will affect their behavior, their mood. It looks like even like ADHD because they are not focused, they are grumpy, they are hyperactive. It worsens mental health, poor quality of life. Poor sleep in early childhood linked with allergy also, with immunity problem, with anxiety, with depression. What's going to affect children with a sleep problem? That will affect everything you can imagine. Their quality of life, their performance, their focusing, their mental health, their diet behavior. They tend to be more likely to be obese. They develop a lot of complications the later part of their life. So adolescents with inadequate sleep have long-term effect on academic performance, and this is in fact, it's very alarming things, as even the American Academy of the Pediatric consider chronic sleep deprivation in adolescents to be as alarming signal as a public health problem. That is how it is really important. Why this happened? Because we are not addressing sleep as a major things. Always looking to things from different angle. The parents, they are not talking about sleep problem to their doctors, and fully they are not watching that. They said go to bed, and they don't know what they are doing in their bed all the time. So they are not giving that much details for the sleep of their kids. And also, unfortunately, the medical community, they are not integrate sleep concept in their daily practice and in daily questionnaire. It's a very simple questions. You have to put it and include it in your practice as a doctor. I think that will solve a lot of problem down the road. As we said, it is American Academy of Pediatric estimate that sleep problem affect 25 up to 50% of children, and up to 40% of our teenagers, they are not sleep, they are sleep deprived. According to the American Academy of Pediatric, a quarter of children under the age of 5, they don't get adequate sleep as per schedule I saw. They have to be, that is, I believe, my telephone. Is it that? Is that one? Anyway, just forget it, please. Leave it. It's okay. Sleep problem include problem of the bedtime, frequent night awake. It affects up to 40% of the infant and children before they go to school. What are the sleep problem? I will speak generally about parasomnias, different sleep talk, sleepwalk, and so on. There is insomnia, there is sleep-related movement disorder, restless leg syndrome, there is circadian rhythm disorder as delay phase or jet lag, shift worker. Of course, this is not for the children, but in general, this is one of the circadian sleep problem. Excessive daytime sleepiness, narcolepsy, cataplexy, all these disorders, you are seeing this more than me, of course. I am just seeing the last paragraph, which is sleep disorder, breathing, and sleep apnea. So these are the parasomnias: confusion, arousal, sleepwalk, sleep talks, etc. I think you know better than me about it. I'll focus. What are the differential diagnoses of sleep deprivation? Anxiety disorder, ADHD, asthma, autism, as Dr. Baktaji very much clear that. Post-traumatic stress disorder, reflux, all chronic fatigue problem, gastrointestinal or asthma, all these things are presented with the sleep issues. Hyperthyroidism, substance abuse, cocaine or nicotine, although by our kids that will affect their sleep. Child abuse, physical or sexual, it reflects itself in a way or another in the sleep. separation anxiety, pediatric specific phobia, and just name it. So all these things affect our kids and give them very hard time to sleep, to fall into sleep, to maintain good sleep, or to wake up fresh in the morning. They are basically sleep deprived. Obstructive sleep apnea basically it is the increasing issues. It is always more manifested itself between the age of between 2 and 6, I believe due to recurrent infections. Prevalence, habitual snoring, it is between 3 and 12 in the preschool, which can also overlap the sleep apnea. Well, kids are snoring, this is say normal, but it's underneath that there is some more serious problem, which is obstructive sleep apnea. And that is exactly going to affect the whole performance, mental and physical, of activity for our children. Sleep apnea, characterized by apnea, stop breathing, or hypopnea. It is decrease of airflow, not cessation of airflow, and obstructive hypoventilation, a period of hypocapnia without a discrete event fulfilling the criteria. It is not exactly hypopnea, not apnea, but it is hypoventilation. So that's what affects the kids. Risk factor, airway narrowing, dysfunction, well, always we said big anedoid, big tonsil, facial, craniofacial anomalies, some syndromic children, different syndromic children, named Down syndrome with the big tongue and so on. They need special approach to do a lot of them. Not only the tonsil, they have a huge tongue base. Obesity, estimated that every kilo you put on, it reflects on the tongue by 1 gram. So imagine if that child put 10 kilo more, there is 10 gram more in that small space in the mouth. So it is, well, apart from the whole things, the neck and all these things, but his tongue is going very big. A neuromuscular disorder, myotonic dystrophy, and so on. Unfortunately, kids, they have a lot of medication and a lot of substance abuse. There is some growth. Unfortunately, sometimes it is down in the trachea, papillomas, and so on. That will affect also the breathing and the sleep. Well, what we expect from, what is the side effect? Well, those kids are more liable for accident, injuries while playing. Because they are not very well rested. They have behavior problem. They have neurocognitive impairment, mood, memory, focusing, learning ability, performance ability. All these things is going to be affected and be. Nowadays, I'll come to this point later on, but when we tell people, okay, look, your child, he got big tonsil. I said, he got no infection. Why should I remove it? I said, look, you don't want to see your child one day, he is labeled like slow learner or difficulty, or he lose that. So it will affect his learning and his performance in the future. There is cardiovascular problem. It will happen as it is increasingly recognized, even in the childhood. That will come in later on in the life. There is a facial deformity because the facial mouth opening, dental, oral problem, overcrowding of the mouth. This is definitely is going to come because of the sleep disorder. The child opened his mouth the whole night because he is gasping for air. That will affect the stability of jaws, of the bones, and it will end up with the facial deformity. So you have to visit the dental for fixing this problem later on his life, anyway, which you could avoid it by other simple measures. So what are the presentation of children with the sleep disorder? They have low focus, low attention, impaired. These are alarming symptoms. If you see a child with low focusing, it doesn't mean he is lazy. Just ask a few questions about how he is sleeping and just watch him. Is he hyperactive? If he shows daytime sleepiness, He might have narcolepsy also as well, irritable mood, aggressive behavior, problems with his colleague, fighting in the class, all these things because he is not rested and sleep well. Also, they are waking up with morning headache. What we can see the child in the night, the family they have to see. They have to go and pay attention to the sleep of their children, not just push them in the room and go. So they have habitual snoring, but watch also if they are choking, stop breathing, mouth breathing, if they have restless sleep, tossing in bed. In the morning, you find his bed is on the other side of the bed, bedwetting, sweating, parasomnias, maybe confusion, arousals, tossing, and so on. All these things tells that there is something going on. You cannot just overcome and say, okay, he will be okay next morning, or close your mouth, why you keep your mouth open, and so on. There is some reason, especially by child, they are not lying when they are sleeping. They show everything they have, so you can't find it. How can we diagnose? Definitely if we increase our interest in this field, we will put, every one of us, we will put in his specific practice some guidelines, some questions that I can reach the diagnosis. For example, as ENT, I'm always asking, is he snoring? Is he wake up non-fresh? Is he obese? For me, he is sleep apnea until proved otherwise. In the neurological or psychiatric doctor, when he sees there is his depression, anxiety, and he cannot sleep well or stay the whole night, then he does sleep deprivation. In children, and so every subspecialty, they can develop their alert or criteria for diagnosis. So clinical suspicion is very important. There is a history, we have to take history, depends on our subspecialty also. But from there, we can reach that there is a problem. All of us, either you are a gynecologist or dietitian or ENT or psychologist or psychiatrist, everyone has approach to the sleep medicine, and they can diagnose the cases from their own protocol if they try to. We have some screening questionnaire. We have to accept that there is some good questionnaires. We have to try to implement it. Physical findings and sleep test, which is the polysomnography or others. History they can include all these things, and snoring, choking, sleep position, daytime irritability, low focusing, some sleepy children, mood swings, and so hyperactivity, low school performance, fighting with the kids at the school, irritable, falling to sleep involuntary during the day. If there is, we have to ask about medication. We have to ask about chronic problem. GI, for example, pain, it gives sleep problem. If you have got asthma, he will have sleep problem. If you got knee problem, he will get sleep problem. If he got migraine, he will have sleep problem. So you have to ask about any chronic condition and try to understand. Those with chronic conditions, they will never be able to have a full good night shut eye. Yeah? So also we have to know that our teenager, they have their own also issue. They are attached to their gadget all the time, watching the phone or computer or whatever it is. They tend, we have to ask if they are doing some after school work, and that will affect their sleep. A lot of low socioeconomic family, they send their kids to work a little bit, and that will affect their sleep. We have to ask if they are doing special exercises or doing, MACH, I don't know what these junk food doing for the kids, caffeine consumption, cell phone, all of this is affect the sleep of our children, especially the adolescent. Screening, there is child sleep habit questionnaire, and there is pediatric sleep questionnaire. They are very long questionnaire. I think they are more towards academic work and research, but not in practical. In the practical, there is something called Epworth Sleeping Score, or Excessive Daytime Sleepiness, or ESS chat. These are widely used by pediatric community to detect the excessive daytime sleepiness among children. So, okay, this score is exactly as it is in the adult, but you can ask these questions to the child. It is 24 score. Yani you ask any question. If you sit and watching TV or reading or whatever it is, do you feel your child doze off, or slight chance of doze off, moderate chance of doze off, or always he doze off when he watch TV? That tells that his eye is shut without permission. So that is called doze off of that child. So with sitting and watching, you have to score him between 0, yes or no. And if it is yes, it is either little chance 1, moderate chance 2, always it is a 3. And then watching TV, sitting in active public, like in a school or whatever, classroom. As a passenger, when you travel in the car more than 1 hour driving, is he tend to fall into sleep? Laying down in the afternoon, specifically for children, if he sit quietly in the lunch, is he doze off? And if he plays his videos and games, does he doze off in there? So these are very important questionnaire you can ask or give it to mom. She fill it, and then you can review with it when the child in the room, and you have it done. You watch the child, you ask, and you look in the mouth, you are reached the diagnosis. Okay, so this score it is below 10. It is normal, supposed to be normal, although it is not very high sensitive according to the phenotyping of problem nowadays of the obstructive sleep apnea. If the score is between 10 and 16, it is suggestive of excessive daytime sleepiness, means he didn't have a good sleep. If it is the score is above 16 to 24, it is high level of sleepiness. So what we can see in the examination, we can see the jaw, the facial, the dental occlusion, large. We open the mouth, we cannot see the wall. We cannot see the wall. Just open the mouth, he open it, and you cannot see the posterior pharyngeal wall. Means the tongue is taking the majority part of the mouth. So there is something wrong. This tongue is full down, full back when he lay down. Large big tongue, facial muscle weakness, shallow cheek, deviated septum, or swollen, enlarged tonsil adenoid that we can see it directly and indirectly as well. Mouth breathing. So, questionnaire. Yes. Questionnaire. Ask the family, examination. You are reaching the diagnosis almost that there is a problem. This is a video I always like to play it to show how it works. I don't know how it works. Is it possible to make it work here? Can we play this video? This is the other video. Yeah. Can you work this video from there? I have to click something? No. I have to click here? Anyway. Yeah. See the child? Very shallow breathing. Look at the chest and the abdomen. This is called paradoxical breathing. He is sleep apnea. No. Nightmare is different. Yeah, it is paradoxical breathing. He looks like from abdomen he is breathing, because the cage of the chest is very, very easy to be. So they are different than adult. Adult tends to wake up here. Children, they have high tolerability. They can stay longer. We can watch the next video. He closed the mouth. He's closing the mouth and breathing. This view is very scary for the family when you see it. And this is really a sleep apnea problem. How I click here, it's not going. Okay, so we are almost there, even without any test, but for purpose of scientific work and to be organized, we said always we should have the test 2 minutes. I am almost finished. The polysomnography, nobody do it for children, only for syndromic cases. There is a home-based sleep study. Nowadays, with the new technology, we can do it very much easier. Oximetry, it helps to convince the family they have to take care about. It's very simple things. They will see saturation is a drop, and then they will, oh my God. So they have to accept to do something for that. Yeah, I'm almost done. Diagnostic metric is apnea hypopnea. I don't need to go in these details. Treatment option is by reduction weight, steroid, nasal, environmental treatment accompanied rhinitis, and then we have AY adenoid tonsillectomy as anterminate reduction. Then there's CPAP, there's a place for some kids. Craniofacial surgery for syndromic cases. Orthodontic appliances, it is there also for our dental colleague, they can do something. So tip, we have to establish a very regular daytime and nighttime, to go in bed one time and specific time, wake up at specific time, either it is weekend or holiday. Just teach them a routine. Try to make the focus on the gadget nowadays. We have to keep the gadget outside the room, and you have to teach the children from day one that they have to keep it outside the room. Make the room nice, tidy, and it should be pleasant. It should not be hot. A lot of people, they believe air condition, it gives us, no, it is good, it should be cold. The good temperature is always above 18, 20, it's always ideal for good night's sleep. So, by this, I am finishing. There are some few tips more, but I think most of what I want to say is just said. Thank you.
Thank you very much, Dr. Abdurrahman. You touched a very important, your time still.
Okay, I'm on time.
Few seconds. Okay, you touched a very important problem we face in our clinic as a pediatrician. I think we'll open the floor first. We'll start with Dr. Suhail.
Dr. Abdurrahman, thank you. Beautiful lecture. Little question. We only opened our eyes recently, probably in the last decade, on the NICU and how the graduates from the NICU, they suffer of lack of sleep because no circadian cycle, because there is day but no night, noise of the respirator or ventilator or oxygen flow, whatever, fans in that incubator. And it's a major hassle when these babies, they go home. They don't sleep and they let mom sleep. And it's an extra burden. I really don't know how to handle this.
The children after discharge from the ICU.
When they leave an ICU.
Yeah, for some time, and when they go home, they will have that problem, right?
That's not pathologic lack of sleep or disturbed sleep. It's physiologic.
Yeah, definitely.
More or less. Yeah.
Yeah, they need something called cognitive behavior therapy. That is the trick for train the kids. I think the psychiatrists, they can do it very excellent. And if you have psychiatrist colleague who interested in sleep and he know how to do the cognitive behavior therapy, that's fantastic. I have adults with this, and they came with the circadian problem, with insomnias, which I don't deal with, but I refer them to a colleague who can do it. I believe that need a cognitive behavior therapy.
I do agree with Dr.
In addition, melatonin and all that stuff.
Yeah, I do agree with Dr. Suhail, this is a problem, but I think they started to handle this long time. They make the diet to be dim during the night time, so the children still keep to have daytime day-night rhythm. So most of the ICUs, including NICU, Pediatric, and even the adult, they are now taking this into consideration, making the time, relate the time with the power of the light inside the ICU, either NICU or BQ or even other.
It's not only light, it's the whole environment.
The whole environment will affect the whole day.
The whistles,
There's a rhythmic noise, rhythmic things going on in the ICU, and you can say also in the factories, the worker when they stay there, they work night shift. Those who are attending flight, jet lag, and all these things.
you know that heartbeat sound.
Yeah, it is rhythmic sounds, Definitely, this is a problem. But there is different, now the technology, there is calculator also. You put on the calculator, it is matching the internal biology, internal clock with the outside clock. So you can align both clocks. When they come together and they understand each other in a good way, you solve the problem. They have some circadian problem, so you have to match their internal clock with the external. Either the family, they are very intelligent, they can book that clock and adjust the sleep by half an hour increment. That is a trick. They can do it with some melatonin, with some whatever it is, nice room, blah, 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 all these things, good. Sleep habit, sleep hygiene, we call it. If they cannot do it, they have to ask for cognitive behavior therapy by a psychiatrist.
We have a question for Dr. Baramara Maduri, and I think it is a very good question. She's asking about the quality of the sleep. Which is more important, the quality or the quantity?
Definitely the quality, no matter the quantity.
And how we can test the quality of the sleep?
This is what we call the sleep hygiene. A lot of people, they said, I spent 8 hours or 10 hours, even the weekend, but I wake up morning. It's a very simple question. If you wake up morning non-refreshed, means you had a bad night's sleep. Very simple question. Do you wake up morning fresh? If he said yes or no, that is very decisive. So, no matter whatever you spend in the bed, 9, 10 hours, it do nothing. You have to have a good quality and a full cycle. A good cycle of sleep is 90 minutes. If you can sleep 90 minutes, now for the mother, they are doing breastfeeding. They have to wake up in the night frequently for that purpose. Well, they will suffer from sleep problem, but they will stay awake for a longer time. Now, the trick is that let the mother take a full sleep cycle and then wake up after that. So she enjoy a full sleep cycle. And then she can do the breastfeeding and complete another 2 cycles. And then she can wake up again. So this kind of full cycle, and there is calculator for that. They can use that. What time your baby should take feeding, she put it on, and she calculate what time she should shut the eye. And that's as simple as this. So by training yourself to have a good sleep hygiene, you will know that you take a full cycle. If you can take 3 cycles, better than 4.5 interrupted cycle. Full 3 relaxed cycle is better than less. So this is the trick. So this is how you call it sleep hygiene. It started by doing this routine, go to bed, routine, go wake up, and so on. It's interesting topics.
How can we adjust for the sleep cycle? You know, it is very difficult. I am sleeping, so I cannot control myself. How can I adjust for the sleep cycle?
First of all, you should do the beginning try. That in a good day, good mood, good time, try to go to bed and watch yourself how long you sleep, when you fall asleep really, what time, and when you wake up, and put diary. So you know your average. Now I know that I fall asleep between 12 until 5:30, something like that. So then don't go earlier to bed. Don't waste your time laying in bed and watching the roof and count, I don't know, the moon or the stars. So this is where you know average starting time and wake up time for you. Then there is some other tricks. You have to improve your circadian rhythm and circadian clock. There is a very simple, God give us this trick. We have to wake up morning and watch the sunrise for 5 minutes. Watch the sunrise with the full eye and watch the sunset with the full eye. This kind of color reflect on the retina and will reset the circadian clock. And there is another thing. So, but anyway, you have to find how it is. If the sleep hygiene is very long program.
What is the sleep cycle?
A sleep cycle, it is start the sleep in the stage 1. So within, there is non-REM and REM. Non-REM, no non-rapid eye movement and rapid eye movement. REM cycle is the dreaming stage, where all the body is relaxed and the brain is work, so it is time to consolidate all the memory.
So these two, how long they should be, or what's the average of REM and non-REM?
REM is about 20% of the sleep. 20%.
No, I'm talking about it's called the cycle. How long?
Yeah, the non-REM and REM together, they are 90 minutes, 1.5 hours.
Okay.
This is a full sleep cycle. That's what I said. If you take it a full, you enjoy that deep sleep. If you take 80 minutes, khasara, you lost it. It depends on your internal cycle. No, duration, this is fixed. Children, they are taking a 60-minute. So, infants and newborns, they are 60 minutes, but when they reach the school age, it goes to the normal. They go to the 90-minute cycle and no nap. If you have a child or young boy above 7, 8 years, take a nap. You have to think twice. There is some problem there. No, this is another thing. Adult, they should take nap because that is like repower, recharge. This is the recharge. Now we need, but you have to know the trick of the nap. Nap has never been a full cycle. It is a power nap. They call it power nap. It takes about 20 minutes. You are fine. If you go to the deep stages, you will wake up groggy and So, but if you have, for example, now the question is that if you have, let's say, an important meeting, you have a presentation, you have lecture, you want to be alert. Now you can take a full nap, 90 minutes, because that will give you a full restored brain and body. But if you want just to refresh yourself before you go back to the clinic afternoon, just take 20 minutes.
Thank you very much.
I want to take the chance for presence of Dr. Abdurrahman. I think we reached the time, but because it is an important point. So a lot of children who are presented with obstructive sleep apnea, and they are treating the patient with nasal steroid without referring the children for an ENT doctor. So I want your input because this is a very important. If the child has obstructive sleep apnea, he has hypoxia for the brain, so the function will not well. He will have deformity for the face and malocclusion of the teeth. So I want you, as an expert, and all of you, how much you are expert in this field, to give a key word for the physician, especially for the pediatrician, not to delay the management of obstructive sleep apnea. This is number one. Number two, many babies who come to us and the family are suffering from lack of sleep. So I think we should take a history about the mother's sleep during pregnancy. Do you agree with me with that or not?
That they take
the second
baby?
The baby, yeah. The baby comes at the age of 3 months or 2 months, and the mother is complaining he doesn't sleep well. He's sleeping by the day and waking by the night. So do you agree that the sleeping pattern of the mother is the determining factor for the baby to be abnormal after delivery?
I think mother should have a good night to sleep, and she should organize herself, as we said, with the sleep cycle. She should take the full sleep cycle. Sleep cycle calculator will help the mother to adjust her sleep to synchronize with the child. Back to the first question, the sleep apnea in children and the importance of adenotonsillectomies and these things. There is obstruction now. Unfortunately, we are suffering. We're not suffering, but we are not in alliance with all community, even ENT doctor. They said, oh, don't touch the boy, don't touch unless there is a recurrent attack of tonsillitis 7-6 times per year, blah, blah, blah. All these things is not wrong. But what is true also as well, that sleep deprivation with mouth opening, it will give very hard time for the family. And that will create, we have children, they are labeled as mentally retarded. They are labeled in the community. They are not progress in the school. They are staying, they are failure. They are not. So as a father, do you like to see your boy like that one day? So this is impossible. So now that changed our mentality totally. We are not considering only the infection as first category for the indication of adenotonsillectomy. And we added now also the turbinate reduction. Not only that, the priority, the behavior problem of the children and the school performance, it's by far more important than the infection. Number two, we have malocclusion. You have to spend that couple of so many thousands of dinar later on in the stage just to correct what can be corrected at early stage by very simple measures. So why you keep asking tonsil immunity you are losing? This is not accepted anymore. This is not accepted, and especially from, we are keep saying this, and there is no single good scientific research and paper in the last 30 years speak about the importance of the tonsil or adenoid tissue for the immunity for children after the age of 2 years. So far, there is no single study. So that the very old teaching is now obsolete.
It's mentioned now that the tonsil and adenoid has no function after the age of 2 years.
Yeah. On contrary, it mentioned. But the classical teaching, still our young doctor, they oh, immunity, don't touch it, leave it, and so on, although he's gasping all the night.
Thank you very much, Dr. Abdurrahman. We end this session now, and I would like to remind you tomorrow the registration the registration office will be open at 8:30. Our first session will be, we have 2 sessions tomorrow. The first one in the morning from 9 until 12, and then there would be a 1 hour break for prayer, and then at 1 o'clock until 4 is the second session. We have again excellent speakers like today, and I really would like to thank you all, and a special thank for our eminent speakers. Thank you very much for your attendance.